Our second speaker, Rik Crutzen, is Professor of Behavior Change and Technology and Head of the Department of Health Promotion at the Care and Public Health Research Institute at Maastricht University in the Netherlands. Professor Crutzen has been supporting our work at the Ludwig Boltzmann Institute as co-investigator from the beginning, bringing in his extensive expertise in the systematic development, implementation, and evaluation of behavior change interventions, in particular using the intervention mapping approach. Rik, we look forward to your talk, Evaluation of Digital Behavior Change Interventions from Idea to Impact. Over to you.
Thank you very much for this kind introduction, Tino. Of course, let me start by sharing my slides, and I hope this works out.
Thank you. We can see the presenter's view perfectly.
Perfect. All right. Yeah, you already mentioned the title indeed. Of course, that was quite generic, and I think the things I have to say are probably even generic beyond digital interventions, but I think I will focus on some specific aspects of digital interventions, because that's also where a lot of my work is focused on, and subtitled From Idea to Impact. I will explain that later on in this talk, but I think that impact really resonates with the idea of do they work as advertised? But I will get to that later. Yeah, I'm located at Maastricht University in the Netherlands, as Tino already said in his introduction. Well, this is the Netherlands, and for those of you who don't know, this in the southern part, in this little tail, this is where Maastricht is located. If people know what it is, because the European Union Treaty was signed there. It's a very tiny city, but you see indeed it's also geographically squeezed in between Germany and Belgium there. So also culturally, I think we have even more resemblance there. If I would speak Dutch, people would know within one sentence I'm from that region. And yeah, my last name is also pronounced as Tino just did, as if there is an umlaut on it. So that's about myself and where I come from. This is how the city looks like, according to the Tourist Information Center. That is actually how it looks like. It's a really nice city, but I'm located in this building. That's maybe not the nicest building, but this is where the Department of Health Promotion is located. It's a really nice department. Of course, I'm biased, but I think one of the things that Tino highlighted is indeed this intervention mapping approach that's followed from a very long collaboration dating back to the 90s with the University of Houston, Texas. Multiple versions of this book. We're currently working on the 5th edition. If you want to know more about the details of this approach, there's a website with all kind of open source, open access resources and so on. Also information about a summer course that we give each year and things like that. I don't go into details about that, but just as some background where I'm coming from. And of course, intervention mapping is not the only systematic planning approach that is there. This is an overview study that some colleagues did, not people I know, but colleagues in the UK did, comparing all kind of different approaches that are there to plan interventions. Intervention mapping is here right in the middle, and you see quite some dots, and that's, I think, one of the key strengths. I would say it's quite comprehensive, following this whole idea of like from initiation or conception towards evaluation and implementation. And in, of course, today's talk, I will focus on the evaluation part. What do I mean with a systematic planning approach? I think it's more, I use it always as a roadmap to guide you. Because the idea is there's a certain health promotion goal that you have in mind, and you make a program or an intervention. These terms are often used interchangeably. And well, that program simply targets that goal. However, if you go into real life, then it often works like this. You kind of go there, you go that way, that way, that way, that way, that way, and then maybe you end up somewhat near or close to that goal. So there's a lot of decisions in that whole process, and I think intervention mapping is kind of guiding you to achieve your goal, to increase the likelihood of achieving that goals in the most optimal way. Yeah, and I deliberately use the words here, increase the likelihood of impact, because I think there's no guarantee. If there's somebody working in behavior change or health promotion at large, and that person tells you this is how you should do it, and then I guarantee you effect, then don't trust that person. We don't have any magic wands, But of course, a lot of decisions are made, and you always want to make, with every step, you want to make the most optimal decision to say, like, given the current theory, evidence, participant involvement, and so on, what is the most optimal choice we can make in this whole trajectory? And I see intervention mapping as a guide on or a roadmap on that way. There are some underlying perspectives of intervention mapping that basically run out towards this whole roadmap. One of them is indeed nothing about us without us. So this idea that you always involve your priority population, but also other important actors in the whole process of developing and so on. So that's one thing. Another thing is that the use of theory and evidence, meaning that you always look at what is already available out there, like what kind of theories or evidence could help me in making decisions. And the third one that is highlighted on this slide specifically is this ecological models and system thinking. I think that has become a buzzword more recently, but the whole idea is here that health is a function of both the individual and the environment in which they live in. So it doesn't help to blame only the individual, saying that person needs to change, or to say it's all the fault of the environment. It's always this interaction between those two that you need to pay attention to. And so they operate in a system. So basically you have all kind of people, they do things in certain settings and so on. And that all has an factors on all these levels have an influence on each other, and they affect the problem. And if you intervene in that basically means you're intervening in a system. So that system can both help and dampen effects. What does it mean for intervention? That you always focus on the interrelationship between the individual and their environment. And the environment can be like the physical environment, but it can also be social environment and so on. So it can also be people surrounding a patient. It can be a doctor. It can be a school teacher, but it can also be a manager at work or whatever. So you also you don't only look at the individual, but you also look at agents at all these environmental levels. And some projects focus more on one level than the other. And that's fine, of course. You also have to make decisions in that regard. But you always know that it's not only a patient or not only an environment change that you need to establish. And these levels or environment are often depicted something like this. There are many variations on this graphical representation. But I think that the idea is that there is an individual that has interpersonal, so friends, families, and so on, that might be in an organization, that can be a school setting, a work setting, in a specific community, in a specific country, and so on. And I think for intervention purposes, it's important to realize that also at all these other levels, there are people involved, and they also make decisions. So that has also to do with behavior change. So you can make a perfect digital intervention for the individual, but if it doesn't match with, for example, hospital care or whatever, then probably it's not going to fly. So you also think at those levels, what needs to happen there? And you think about that in terms of intervening, of course, but more related to the talk, to the topic that we're talking about today, also in terms of evaluation. So of course, you collect often a lot of data at the patient level, but often also at higher up levels to see what went well and what didn't go so well on those levels. So this is a kind of an introduction. One more thing about intervention mapping in general, indeed, this is just a graphical representation of the steps that you take. So basically going from there's a specific problem. That's always the point of departure. So there is a problem in practice that you want to address, and there is something that has to do with behavior, and it can be a behavior of patient, of doctors, of nurses, of school teachers, whatever. And then you start thinking, okay, any desired outcome, what will that be? And there's a whole chain. I will talk more about the chain later on. And then you start designing your program or your intervention and ultimately make it. And you think ahead about implementation and evaluation. And what you see here, that's in italics, actually, it's an implementation plan and an evaluation plan. So that means that this is at the stage before you actually implement and evaluate it. And this is also an iterative process. So that means you cannot start producing your intervention without knowing what is the exact problem I'm talking about. And the same is you also, in the end, need to have an evaluation plan before you actually start doing the evaluation. So this is an iterative process, of course. You move back and forth, but there is a dependency between those steps. So the decisions that you make in step 2, for example, they directly affect both your intervention content, but also later on what you're going to evaluate. And I will get back to that later in this presentation, but just as a general introduction. And well, normally these are the end, but I already tell them at the beginning, and I will get back to them in at the end. Of course, I hope you stay with me, but if for some reason you can't, I hope you remember these things, that you think about impact right from the start. And that is also what I wanted to show with this slide, that you make a lot of decisions here at the beginning, but they affect later on your evaluation and also the ultimate impact once you start implementing something. And then the choice of your study design depends on the specific evaluation question you have. Well, that sounds obvious, of course, but I think there's a lot of possible evaluation questions. And I'll also get back to that, of course, in the talk, but I think that resonates with this idea. Do they work as advertised, and what kind of impact they have? There are a lot of possible questions. And from that, I think almost automatically follows, but I'll hope I convince you about that during this talk, that there's a wide variety of study designs are needed to solve the puzzle. And each study design has pros and cons. Eleonora was already talking about pros and cons in terms of the impact it has of the number of people or the number of data points you need. So that's one of the aspects, but also I think more generally, they bring different pieces, they solve different pieces, they are different pieces of the puzzle. So I think my talk is not to say this one design is better or this one, but they all bring something to the table. And that's what I will talk about more in this talk. How I structured this talk is probably no surprise. I focused on the specific task. So the 6th step of intervention mapping is coming up with an evaluation plan. And then there's 4 tasks you need to do in that specific step. And that is also how I structured my presentation then. So basically, I will guide you to these 4 tasks, and then I hope I bring this to life a little bit with some real-life examples, quite a lot of them from my own research or research that other people did, to kind of give you an idea about these take-home messages and to bring them to life more. So starting off with this first one. So basically, these are a lot of technical terms, I realize. But I think the key thing here is that all the decisions that you make beforehand in setting up your program, they should come back in your process and effect evaluation. Or you make a deliberate choice not to focus, not to evaluate them. That can also be a deliberate choice, but I'll get to that later on. So this is in a very simplified term. What you do in an intervention, or what you hope to do, as I said, we often start, or I think we should start, from a health problem. There's a specific health problem that leads people to have a lower quality of life or have an impact otherwise. And then you start thinking about, okay, what kind of behavioral factors and environmental factors are related to that, and why do people behave the way they do, or why do people in the environment make the choices they do? So that's a problem. That's in step 1 of intervention mapping. And then you translate that into what we call the flip in step 2, like, okay, after the intervention, what do you want to achieve? So that is health and quality of life. Of course, you want this health problem probably to reduce and have a positive impact or contribution to the quality of life of people or patients. And in this case, we focus on, okay, behavioral aspects and environmental outcomes related to this. And often there are sub-behaviors. These are performance objectives. Don't worry about the technical terminology here. But you always think, okay, why do people behave the way they do, and what needs to change there? And as I said, in intervention mapping, you think about environmental outcomes, and these are always things that are, in theory, changeable. So we don't talk about the weather. Maybe the weather does have an impact, but then we cannot change the weather, of course, unless we think about some divine intervention. But that's not something that is changeable. Maybe there is ways to deal with the weather, for example, but often in the behavior change interventions, we think about things also in the environment that are technically changeable. So that means that there is also an agent that is responsible, quote unquote, for this. So you think about, okay, what does this nurse, this doctor, this high school teacher, or whatever, what do they need to do to change this environment and the outcome? And then you might realize, so for example, I don't know, you start intervening in the school, you start talking with school teachers, and then they have a certain influence, but they say, yeah, but it also depends on my director. So that these environmental agents, they also have an environment that they work in. And that is these layers that I just showed in this socio-ecological model. And then you also start thinking about that. And that also means that when you intervene, of course, you intervene on all these levels, or you could intervene on all these levels, but also your evaluation then would also take place. So of course, probably the teacher needs to do something different than the high school kid. And the same goes with the patients, probably needs to do something different than the doctor or the nurse. But they all need to do something, or you hope to establish some change in them as well. So you also involve them in your evaluation plan. So I said here, you do the flip. And that sounds very simple, like you go from unhealthy to healthy, from the health problem to some healthing. So the first question that you asked is, what needs to change in the behavior and the environment to have these improved health outcomes? So that sounds like going from unhealthy to healthy behavior, unhealthy to healthful environments. But I want to stress that this is not simply the opposite. So let's take, you have a certain health problem that has to do with unsafe sex among adolescents. Then there are loads of possible, if you make the flip, a load of possible options. So you can say, okay, maybe I don't want these people to have sex before marriage. I can tell you that's a very ineffective strategy, but that is still the case in some countries and states where they preach this. Or you can say no penetrative sex, or use condoms, or test for STDs, or a combination of those. But I think this already shows you that this has an impact if you focus an intervention on condom use, or you focus an intervention on testing for STDs. That will be a different kind of intervention, but also in terms of evaluation, you would evaluate them completely different. And that's fine, of course, but that's a choice that you already make. So that's, I think, during the initiation phase, you already make choices like this, and that has an impact on the intervention, but also how you evaluate it. So another example, this is about MDMA or ecstasy. It is commonly used at parties. You can say, okay, there's certain risk or not involved or related to this. You can say, okay, not using it. And often I think the law supports this. Often in most countries, it's still forbidden. But it doesn't mean that it's not used. There are also countries who say, okay, we kind of take for granted, not that we accept it, but we take for granted that people use it. But then if we use it, we want to have a more harm reduction strategy. So we encourage people to test their pills and so on. You can imagine that the intervention looks different, but also how you would measure the outcome, because you would measure different kind of outcomes. So this is just to say that a lot of choices you make during the initiation phase, like already what are your goals of the intervention, impact the evaluation of it. All right. And also a fact, oops. Now, there it goes. Sorry, there was a problem with clicking. Also affects the behavior change methods that you use, or behavior change principles. And these are basically what I would call the active ingredients in your intervention. And they are called behavior change principles or methods or techniques. And in a certain way, I think that's kind of a misnomer. And why is that? Because I think they don't directly change behavior, right? Unless you go for coercion or something like that and tie people to a chair. But that's often not what we do. What we do is we have some general principles or theory, methods, techniques, and so on that we know from the literature that work in principle. But then you translate them in your intervention into something tangible, an application. And that can be a digital application. And that kind of influences how people think, react, feel emotions, discuss, reason about certain things. And that then has an impact on health behavior. So this is kind of the whole change of behavior change. And I have an example here. Um, this is what I call the causal structural chain that is there. I will get you to this. So for, let's say, here's the example is here. The target behavior is that we want to reduce transmission of STDs. And then possible sub-behaviors, for example, might be that you stimulate people to test their STIs. And in case of positive, they say treatment, in this case for chlamydia. And there might be different determinants related to that, like attitude or self-efficacy. Again, this is a simplified example, but then in your application, you might have a specific web page, for example, about chlamydia testing, and you have certain methods that you use on that page. So this is a whole chain that is there. And as I said, this is just zooming in on one specific page of one specific website. But in your evaluation, then you can also like evaluate all these aspects. So starting at the end, of course, if you say, I want to prevent transmission of STIs, then the number of STIs could be a very relevant outcome. But also all steps before. So whether people go for testing or whether people seek treatment, that can be behaviors that you also evaluate. And also the step before that, the determinants that you find important. So why do people behave the way they do? So to what extent they feel capable of, to what extent they think they are convinced that testing for STIs is a good idea. That's also something that you can evaluate. So you can evaluate this whole chain, causal structural chain. And why is this important? Because then you also see where things go well and where things don't go well. So it could be, for example, that you're perfectly capable of changing all these determinants, but it doesn't translate into the desired behavior. And then it might be, okay, maybe there's other possible determinants that we forgot to include. And then if you would develop the intervention further, you would make another choice. You would say, okay, maybe there's also a very habitual element to this. I'm just making up this example here, and then we need to do something about habitual behavior as well. It could also be that you do your evaluation and did you actually find, hey, we thought self-efficacy was really important. So to what extent people feel capable of doing this, but our intervention element didn't manage to change that. So then you would have a different story. Then you would have like, okay, I need to change the intervention in terms of seeing to what extent can we further improve self-efficacy of people participating in this intervention. So this is at the determinant level. That could be you need to target different determinants or you need to target these determinants differently. It can also be that you find that a lot of people go for STI testing, but then don't seek treatment. So then that's something that you need to fix. Or you find that people go for testing and go seeking treatment, but it doesn't necessarily test their transmission of STIs. Maybe something they need to go earlier or something like that. So across this whole chain, there are a lot of different possible ways where you can improve your intervention later on. Yeah, I added a reference here because I took this very snippet I took from an existing intervention, which is way larger and has way more of these chains. So I added a reference in here, and for your reference, all the references that I've mentioned here, throughout this presentation, they are open access, so they are all clickable and so on. And I'm happy to share the slides after this presentation, of course. And if you're interested in making these causal structural change yourself, we also developed a web app where you can make them. And basically the input is very simple. It's an Excel sheet or a Google Doc, a Google Sheet that you can feed into this, and that makes these graphical representations. And I think these are very useful, both for yourself as a kind of to see literally, are there any missing links in your intervention and so on, and to discuss with your program team or with people that you develop your intervention with, okay, what is our rationale and how should it work and so on in theory. But it also had helped me a lot to, especially in a digital realm, when I start talking, for example, with web developers or technical people more in general. As you see, there's a lot of terminology in here. And most of the times these people, they know a lot about tech, but maybe less about behavioral science. And the other way around, I know a bit about tech, but I'm definitely not a technician. So it helped me often to kind of bridge this gap, to communicate with these folks, okay, this is our rationale. Can you translate that into a website page or a digital application or whatever you have in mind for that specific intervention? So I also use it as a communication tool. Like during the process, And I think it's also valuable to report that in your intervention later on. When you write a scientific publication, I mean, but also just in general to document your intervention and decisions are made. So this whole chain then ultimately leads to an effect or a desired effect on behavior and therewith on specific health problems. And you might have noticed that I use the word impact in the beginning. And this idea is fueled by, for example, re-aim. And I think that also echoes this idea, the overarching question or title of this session. How do we know whether digital health interventions work as advertised? And I think this advertised has to do, of course, with effectiveness. So this is this whole chain. Does it lead to the ultimate, the desired behavior chain? But I think it's way more broader. And re-aim is a kind of framework that conceptualizes the impact of an intervention depending on 5 factors that are related to each other. And the first one being reach. So you can have an intervention that in theory in your RCT, it works perfectly. And then you put it out there in the world and nobody uses it. I think that's a no-brainer that these two should be like in balance. If you have the perfect intervention that nobody uses, you will not have an effect. So it's this reach and effectiveness. And of course, also adoption, implementation, and maintenance. And that has to do what I said with all these other ecological levels. So if you make a perfect tool, but no school uses it or no hospital uses it or whatever setting you work in. So this adoption, implementation, and maintenance is also crucial. And in my view, these are also behaviors with different determinants. So adoption is more the decision to use something in the first place. Implementation is to use it as intended. And maintenance is to keep using it in the long run. And people have various reasons to do that or not do that. And of course, I'm definitely not the first one to think about these things. There's a whole field of implementation science focusing on this whole idea of how can we stimulate adoption, implementation, and maintenance. And that often goes about these higher up levels, so like these nurses and doctors and so on. But I think this also works at the individual level. Also, as an individual, I need to decide to use a digital tool, and I need to use it in the correct way. And the correct, I don't mean in a normative way, but more like as intended to have the effects that is desired by the developer. And I think with a lot of interventions, sometimes there's a one-shot behavior, like going for vaccination or something like that. But I think with a lot of interventions, Tina mentioned they do a lot of work. We do a lot of work at the LBI in terms of physical activity. It doesn't help to go to the gym once. Often these are the things that you need to do in the long run. All right, so this about the first step. So this all the decisions that you make about how your intervention looks like. That is all, I think, almost like a framework that you use for your evaluation plan. So that is what you're going to evaluate in theory, and then how to evaluate that. And then the 2 tasks in intervention mapping are the process evaluation and effect evaluation. And I think process evaluation often has to do with a lot of these things that I just mentioned as well, but also with adoption, implementation, and maintenance, but also how did people reach the effect or not the effect that was desired. So I'm going to focus now on a more process evaluation, and I'm going to do that by an example. Actually, this example is fueled mostly by the work that is led by Guido Metz. He's a former PhD candidate who defended his thesis earlier this year. And his work focused a lot on sense. Sense is, well, it's part of a step care model in the Netherlands, but his work focused on the website, which is like the main entrance point for everything about sexual healthcare for youngsters in the Netherlands. And so that means that it also is very broad aim. So it really is about informing youngsters about all kind of things related to sexual health. And it can have to do with kind of which kind of type of condoms to use towards crossing boundaries, towards sexual identity, and so on. So it's very broad. And this is, as I said, it's the beginning, the entrance point of a stepped care model. And some people might need to have more advanced care. For example, have a one-on-one chat with a nurse towards ultimately going to the SDI clinic. But of course, we don't want everyone there, only the people who need to go there. And it's been around since 2009. And it has been, well, these are the somewhat older numbers, but still you can see that it's very highly used. And maybe Just to give an idea, there's only 18 million people living in the Netherlands, so 6 million is really a lot given the population size of our small country. So it has been around for ages, but there was no insight into potential impact. So that's why this NGO approached us. Can you help us to get more insight into this impact? And we use it kind of as a use case to focus on this cyclic evaluation process. That so his PhD thesis was about applying this to this sense.info, but also to kind of demonstrate what the potential added value of this cyclic evaluation process is. And I think you recognize this slide. So we started off by first analyzing, okay, what is the idea? So together with these intervention developers, we talk, okay, what are your ideas? And we made things like this for the whole website and all elements that were on the website. And it was really big. So this is really just a snippet of all the many things that we had there. So this is in their ideal world, how they imagined all these things worked. Then in the next phase, the beauty of it is that millions of people were already using this website. So that for each and every page, we had a lot of insight in the actual use of the intervention. I again refer to a publication where you can look at all the details. But I focus on the chlamydia page, that example I used before. And then we saw, for example, that was to stimulate STI testing. And we saw that 14% of people visiting this page actually went to this area where they could go for STI testing. Okay, that's of course a number. So these numbers are really valuable, but it's kind of hard to say, is this good or is it bad? Because it really depends on what kind of people get there and why do or don't they get there. So then as a third step, what we did is we did qualitative work with people that visited this page of the website. And then we did like tingle out sessions with them, followed by semi-structured interviews. Of course, I can't tell you anything. There's a lot of rich data. And again, the paper is there if you want to have more details. But you saw several things. So for example, one thing is that they use this kind of as a self-diagnosis motive. That was for some visitors. So they look at the website and they look at the symptoms and things like that. And they kind of decided, okay, I'm not at risk. I don't need to go for STI testing, which is actually a good thing because you don't want people to unnecessarily go. So the self-diagnosis is actually, then you miss out that certain people don't go to STI testing, but that's not a bad thing. That is the selection you want with the stepped care idea. Other people said, well, I need to go, but I go to my GP. And that's fine as well. In the Netherlands, you have two options. You can go to your own GP, family doctors, or you can go to the STI clinic. A lot of people actually prefer the STI clinic because it's more anonymous, as in they know their family doctor, but often they don't know the STI clinic. So given the sensitivity of the topic, that's what a lot of people prefer. But of course, it's perfectly fine if they go to the GP to have their test there. That's also fine. There were other people who said like, oh, maybe I want to do it, but I didn't see where this link was. That's, of course, a bad thing. That's people who potentially were interested in testing, but didn't go there. So we also talked to them, how can we improve that? There were things like people talking about adding personal stories. There were people who were concerned about the use of language. So even just things like, yeah, it's always hard to translate quotes, but consultation hour to them had a very scary connotation. I still don't get it why, but that was something that was scaring some people off. Other people say, oh, you don't have an option for tailored advice. So these are just some examples of input that we got from these think aloud sessions with interviews. And we then in the fourth phase use that to optimize this part of the intervention. And we did this for the whole intervention, but just as an example. And so, for example, this STI testing, we gave this a more prominent spot on the website so that everybody who could see it would like to go there, could easily go there. The other thing, that this comment that was made about this tailored advice, it was actually there within Sense.info, but it wasn't linked to that specific page of the website. So we added that also on that website. And the third thing is these role model stories. That was the next step. And we did a whole study about that as well. So I won't go into details about that. But that's how we then optimize it. And then the circle goes from start. So we kind of change, okay, this is intended use. And we look at the numbers again and so on. So that helped us in a more process way to gain more insight about the potential impact. And so this indeed, we use semi-structured interviews and think aloud. And this paper kind of gives an overview about all kind of engagement methods that you can, research methods, sorry, that you can use to get more insight into engagement with your intervention. And I think that's very valuable for this process kind of evaluation. So we did that with, in this case, with semi-structured interviews and think aloud. So these are more qualitative methods. But we also give examples of methods that you can use for more quantitative. So they're looking more at this user data. But we did the same for sensor data, social data, psychophysiological measures. So I think this is the kind of paper I would have liked to read when I started a project like this. I think it's helpful. So that about process evaluation. Then effect evaluation, and I think a lot of things are already said about this, but there is an order to this as well. So you have your questions, measures, and then study design, and I think that also resonates with the overarching thing I want to say. So you always start off with your question and then go to the measures and ultimately the design, and the context matters. So what do I mean with this? You might have noticed that we didn't do an RCT in the case of Sense.info, and that was a deliberate choice. And that was, I think, fueled by two things. First of all, there was no sensible primary outcome. This website covered sexuality in its broadest sense. So it was really about which type of condom use should I use? How should I talk about coming out of the closet with my parents? What if somebody crosses my sexual boundaries? Where can I go for STI testing? So all this was covered. So if you would say our primary outcome is STI testing, that wouldn't make sense because a lot of people came on that website with completely different expectations and questions. So that wouldn't make sense. And I think that also fits with the larger idea of personalized medicine, that you have an individual outcome and sometimes also an individual treatment. So that was one thing. And the other thing was, there was no sensible control group, unless we do like, you cannot look at any website kind of thing, because this website was already nationwide available. So we couldn't like blind people or say in this region you have access, in this region you don't, because that was already nationwide coverage. And this website was available for over a decade. It was promoted, all youngsters know this website. So in this case, that doesn't make sense. And I think this fits with a more larger thing also. So this was work we did during the COVID pandemic, actually, where we looked at digital contact tracing support tools, basically ways in which we can help people to prepare to support public health professionals in contact tracing. And of course, and does it work? Well, it depends. There's a lot of possible questions. So you can have, okay, I need to find as quickly as possible all contacts that you had, or I need to have as many as possible, or I want to reduce the workload. So these are all possible outcomes that you can have, and they might require a different design. And it can be that an RCT is the perfect solution to that, but for some questions, it might not be the case. So again, it depends. And I think that fits in the broader context of, you see more and more the valuing of various studies design. So the UK Medical Research Council, for example, they recently updated their framework, also valuing this. There's a specific guide for electronic health evaluation approaches. More locally, well, in the Netherlands, there is also this recognition where they kind of literally say, okay, we need more kinds of evidence fitting into what you want to know. Doesn't mean that I'm against or pro cluster randomized controlled trial or whatever. Of course not. It kind of depends. So in this example, we focused on alcohol consumption of youngsters, and we did this in a school setting, and there was a serious game attached to it and so on, and we did that, and it worked perfectly, and it gave us the answer that we want to know. And well, I don't want to go into a lot of details about this project, also given the time, but what we found here, that the intervention was effective. We also found that the more you use it, the more effective it was. And well, the specific context was, this was when they changed the legal drinking age in the Netherlands. So this was specifically focused at youngsters, and that was more effective with youngsters than with older ones. So that was very valuable. Maybe one more thing about RCTs. I think another thing there is what is happening in the control group. This is work led by Marijn de Bruin. And what he actually showed, that we often say, like, okay, and the control group receives standard care. He actually looks what is happening in this standard care. And he tried to quantify that. And then he plotted standard care against the outcome. And this was about HIV viral load. So actually what you could see, the stronger your control group, the more impact it has on the viral load. Of course, that is a no-brainer, but you can imagine if you synthesize this kind of evidence, this has an impact, right? You should look what is going on in the control group as well. Even if people say, I use standard care, well, you see on the left figure here that there's a lot of variation in what standard care is. And then I don't go into this was an example of an N of 1 study, but I think Eleonora just perfectly explained all of that. So this is my referral and shout out to Eleonora. Then ending with the final stage is that you pilot, test the intervention, and then finalize the evaluation plan. So that this is kind of with this order that you showed in the beginning. So you also pilot as the intervention. And two things I think I want to say about this pilot testing. I think the key thing is that you mainly do this to identify unforeseen problems that could compromise the quality. So often what it leads to is, for example, adaptations to study protocols or materials, or to contingency plans, like how to deal with difficult situations and so on. So I think often with these pilot studies, you're not powered to assess effect sizes. You should power them also to detect problems. And again, this publication and this website, there is very simple tool to kind of power your pilot studies with the idea to detect unforeseen problems. And that's the last example I want to give. So this is a digital intervention where we focus on actually people who volunteers to go for STI testing on a website, and they order the testing kit so they can do it at home privately. And we saw this as a window of opportunity because this is a high-risk group, to also tell them about condom use and so on. So we did a May trial, and we looked at, for example, the recruitment and retention strategy. So we looked at how should these messages look like and those kind of things, which kind of value propositions, which kind of newsletters and so on. But we also monitored, for example, unwanted disclosure, adverse event. And one adverse event was that, for example, we sent these people also a free test kit of condoms to their home with a neutral packaging and so on. But that still led to that some people then said that asking that they, for example, their flatmates or something were asking what was in that package, even though it had a neutral coverage and so on. So based on that, we had as a contingency plan then implemented that they could also send a different address if they would like to, like their pickup mail kind of thingy. And I'm happy to say that this was a pilot study, and we now got funding to do a full-blown RCT as well. So I think that brings me to the end, and I hope I then convinced you about these take-home message I presented at the beginning. Think about impact right from the start, and your choice of study design depends really on the evaluation questions you have. And I hope I introduced you some kind of study designs that you could use to solve this problem depending on the specific question you have. And that might sound complex, but I think we need to embrace that complexity to say something about, do these digital interventions really work as advertised? And with that, I would like to thank you, and I give the floor back to Tino, and I stop sharing.
Thank you very much, Rik, for this very, very nice and comprehensive and differentiated overview. And I will just sort of add a few keywords that I picked up, because I really enjoyed how you brought together this complex view, looking at behavior change interventions in a holistic way, taking the angle of intervention mapping, also bringing in implementation science, which is a growing field and an increasingly important field, to help us get evidence-based interventions into practice. You touched on the United Kingdom Medical Research Council framework for complex interventions with their process and effect evaluation dichotomy. And my big takeaway is to look at a digital health intervention from the developer's intentions perspective, and considering the context in which it is implemented, and embracing the plurality of study designs and methods. So there is not the one gold standard study design, but depending on what type of digital health intervention, depending on the context it is used in, we can draw on a diversity of research methods and study designs.